for our first event of the year for the 2021-22 Seminar Series for the McMaster Institute for Health Equity, which we tried to present timely health equity focused research on a diverse range of topics that is relevant to researchers, student staff, and community members across a range of disciplines and backgrounds. We will begin by giving honor and thanks to the Haudenosaunee and Anishinaabe nations as the traditional inhabitants of the lands where McMaster stands. To say that is to acknowledge a debt to those who were here before us and to recognize our responsibility as guests to respect and honor the intimate relationship Indigenous peoples have to this land. We are so pleased to have Dr. Yukiko Asada present with us today. Dr. Asada is a professor with the Department of Community Health and Epidemiology, Faculty of Medicine at Dalhousie University, and fortunately a visiting scholar here in the Department of Health, Aging and Society at McMaster University for the 2021-22 academic year. She obtained a PhD in population health from the University of Wisconsin-Madison, and her research program articulates concepts of health and equity and promotes public dialogues on health equity using an interdisciplinary approach, integrating ethics, quantitative methods, and policy. Today, Dr. Asada will introduce us to the Fairness Dialogues, which is a new method that she and her colleagues at Nova Scotia have developed for engaging the general public in deliberation about health equity. We're very much looking forward to hearing about this innovative project and method. So I will now turn things over to you, Dr. Asada, to get started. Thank you.
Thank you. So let me share my slides. Sorry, I'm just sorting out my little screen. Okay, so everything good? Yeah, looks good. Okay, thank you very much. Thank you for the invitation to talk about my work, especially the organizers and Dr. Marissa Young and Jim Dunn, and also logistic help from the Miss Lindsay Goddard and Miss Equity Burke. And first of all, apologies for this somewhat undescriptive title of the talk, and I hope that you will understand what that means and as the talk goes. So here you go. Oops, sorry. Okay, so today I would like to talk about fairness dialogues, new method for deliberating equity and fairness issues in health and healthcare among laypersons. And then I developed this methods with my colleagues at Dalhousie University, Marion Brown, Andrea Murphy, Grace Warner, Mary McNally, Marika Warren, and Robin Urquhart. And during the presentation, probably I just use interchangeably I and we, but this is pretty much the collaborative effort. So we did it together. And then today, my plan is to talk about motivation, why we developed this method, and design of the fairness dialogues. And I would like to introduce a little bit of the empirical illustration, how it actually looks like when we apply in real world, and also future directions. So first, the motivation for the fairness dialogues. The public increasingly plays an important role in the health policy. And a simple question of what do people think drives many public engagement efforts. Posing this question is particularly meaningful when issues relate to values such as equity and fairness, where the right answers cannot be found easily or at all. So for example, at the beginning of the pandemic, the COVID-19 vaccines, we still didn't have it, and then we are going to develop. And at the beginning, we thought that there will be shortage, and who should get what, in what order. We talked a lot in academic literature and policy literature, and then also some academics did ask people about their opinions. So that's a kind of a very temporal, the timely example. And in this presentation, I shall refer public engagement in value-laden questions as the public value elicitation. And in public value elicitation, equity is often acknowledged as really important, but and it's often, I think, it's like a kind of black box. So even before COVID, priority setting, healthcare resources are scarce. So we did ask public who should get the priority of getting healthcare resources. And then there often equity comes up very important. So it's there, it's labeled, but in what does it mean? It's really elaborated on what that means in the context. And then here I'm talking a lot about equity, but then why am I talking about focusing on equity? Well, I believe that the well-functioning health system is not only effective and efficient, but it should be also fair. And some other way to say it is that the health system, I believe, is a social institution and should embody social values. So I don't think it's enough for the healthcare system to fix people when they go ill or injured. And it's not enough for the healthcare system to prevent them to become sick or injured. But it's also important to think about how we do it, and that how component should be informed by the social values we share. And the bad news here is that an equity is a complex concept. So as the Marissa mentioned at the beginning in introduction, I've been doing this work for some time. And then people come and say, ask me that then can you give me the definition of equity in a very concise way? And I said, well, I can't, because there are many, many different competing views and they look reasonable. And then unfortunately for us, it's contradictory. Sometimes they don't agree with each other. So over many years, I've examined different concepts of equity in health and then thought about how best to reflect the different concepts we chose to reflect in the measurement of health inequity. But the more I study, I began to think that then maybe the right answers, what is fair and what is not fair, may not be out there for me to discover. But rather, maybe there are many, many right answers, and which one is the one we use is actually very dynamic and context-specific and time-specific. And we need to kind of get together and explore it together as a society. So this is the fundamental motivation for me to wanting to develop fairness dialogues, a forum to do such collaborative elaboration. So now I want to move on and tell you about the design of the fairness dialogues. So given the reasons why I wanted to ask people about their views on equity issues that I just explained, what we're after here is not the gut feelings. I wanted to know reflective values derived from a careful thought process. And then I thought about how should I go about, and then of course we go back to the literature and what can we learn from it. And there are two things I could learn from the literature. One is that then why we ask people, and the other is how we ask people. So those are connected. Like once we clarify that why we are asking people, then maybe there's some methodological direction we can get. So why we ask people? This is my understanding of the relevant literature. There are 4 different reasons. So one is foundational. It's essentially to understand what people think, laypersons think. And why is this important? Well, because I think in academic training, it's not that we gain knowledge, but then we start to think in a certain way. So it's the way to organize our thinking is the academic training. So it's usually good, but then if we continue to do that, we kind of lose the initial point. So we start to, all of our colleagues start to think in the same way. And then it's good to go out and then ask people who don't have that training. And then sometimes they will tell us something we should have asked, we should have understood, we should have noticed. So for that reason, it's foundationally, we want to understand what people think. The second reason could be instrumental. So this is to act upon what people think. And there are 2 important distinctions. One is direct directly instrumental. So imagine that then you have one policy decision you need to make, and you want to elicit values from the public so that then you can inform that particular policy. So that's direct. But there's also, and then I should give you some example here, Citizens Reference Panel on Health Technologies in Ontario derived the core values for health technology assessments that way. And that is our colleagues' work by Julia Abelson and Amita Giacomini. So probably you are familiar with their work. The other indirect instrumental way is that there's no single policy we're interested in, but we want to develop a set of guiding principles that could inform multiple policies later on. So the example here is that the Citizens Reference Panel on Health Technology, it's the example is the Citizens Council in the National Institute for Health and Clinical Excellence, NICE, in the United Kingdom. And unfortunately, this is discontinued, but for a long time, they've elaborated the social values by asking people. The third one is the process-oriented. So by asking people, we can show respect to them. And then also we can increase legitimacy of the policy we're making. And then finally, it could be educational. So it's that to enhance capacity among the laypersons to talk about difficult value-laden questions. So these are the different reasons you can find in the literature. And for the fairness dialogues, we wanted to do all, but except this direct instrumental. We are not interested in particular policy. Rather, we wanted to kind of really elaborate social values, and maybe if we could develop a set of guiding principles to inform many policy decisions that we have to make later on. So that's the intention. So now moving on, how to ask. Well, there's so many methods in this value elicitation area. So surveys, experiments, focus group, and deliberation. And even within it, there are many different variations. So for example, deliberation as a citizens jury, citizens panel, council, deliberative poll, and town hall. So each of these slightly different. And the literature is really multidisciplinary. So health sciences, public health, health services research, they use certain methods, social sciences, sociology, political science, economics, health economics, they all use different methods. And my observation is that the choice of the method is often driven by the disciplinary orientation of the investigators. So they just, well, my colleagues do in my field, and this is the default. And this is a problem for me because my academic upbringing is interdisciplinary and multidisciplinary. So I don't have any default discipline to go back to. So I needed to really see like which one, how can we choose? And this is very difficult to know like what's the advantages and disadvantages of the different methods across disciplines. So I discovered this Schneider, and Kahn article, 2008, to classify different methods out there and make sense of it. So their interest is a deliberation. They wanted to kind of think through that, what's the characteristics of the deliberation and then how that is different from different methods. And then they have this 2x2 table. And the first one they looked at is that, it went too wide. Interactive context of communication. Essentially, are you communicating alone, yourself, or communicating with others? And the other is the rules of communication. You do not need to specify, that's one way, but the other is the reason giving, inclusive ethics. So by reason giving, participants are asked not just to talk and offer opinions, but to provide reasons for their views. By inclusive ethic, participants are asked to listen to each other and remain open to new proposal. So for them, they say that we can start to see different methods in these four different four areas. So one is deliberation, which is reason giving, inclusive ethic, and communicating with others in a group. If the rule of communication is not specified, it's just discussion or just talk. That's their word. And then it's unspecified communication, but doing alone is a spontaneous essay. And the last one is that then you ask people to be reason-giving, inclusive, but then do it alone. So it's called the internal reflective mode. And then there's actually quite interesting subfield in deliberation that then can you deliberate alone? You know, is it better to deliberate with other people? So anyway, so this is the classification. And I think this maps out quite nicely with the typical value elicitation studies we see in health area. So here, focus groups, deliberation, opinion surveys, probably you are familiar with these examples. Probably one thing I should give you example is the questionnaire-based experiments in health economics. So it looks like this. This is the study by our colleague, Jerry Hurley. And I'll just let you read a little bit about what this looks like. Okay, so you got an idea, like a very stylized ideas. And then, so this is a lot of in health economics, this kind of a questionnaire-based experiments are used a lot. And I think this, they're trying to get reason-giving, inclusive ethic, but in it doing alone. They're invited to the lab and then they think through. So for the fairness dialogues, which one we want to choose? We wanted to have reason-giving and inclusive dialogue because of our interest in deep thoughts rather than gut feelings. And then also because the fairness dialogues is a forum to explore social values collectively, we thought that then communicating with others is important. So these are the, we thought that this will work. And here, reason-giving and inclusive dialogue, even if we want it, it doesn't happen naturally. It's just, we need to have some kind of a strategy to make this happen. And these strategies, the existing studies use a variety of strategies, and they attempt to address potential factors that prevent reason-giving and inclusive dialogue from happening. So, for example, people may have a hard time thinking beyond their personal experience and a circumstance. And the personal anecdotes can help assess the collective thoughts, but in too much of it, it's probably distracting. And you can also think about other cases that people may also be uninformed about the topic or informed in a certain way, but in a not that all-inclusive way, so that then they cannot appreciate other perspectives. So these things and existing strategies try to accommodate that. And so we thought, what are those strategies and how we can make sense of it? And continuing with this 2x2 table way of thinking, we came up with this. So we can think about, well, sorry, I'm moving around. Okay, good. So we can think about who the participants are asked to be. So bringing oneself or someone else. And the other is that the context within which questions are posed. Is it a very stylized hypothetical or real world? And if you think that way, those examples we see in the literature kind of fit in. So recall that the health economist questionnaire, it is the example of the stylized and the hypothetical situation and bringing oneself. And next to it is the deliberation. So they don't use those stylized examples. It's the real world questions. And then they ask participants to join as themselves. But what they try to do is that, okay, so they are not quite ideal citizen. So they want to turn them into the ideal citizen and see what they discuss. To do that, deliberation often give a lot of information and then also the different perspectives. So the bottom non-self part is the one is the John Rawls veil of ignorance. So philosopher John Rawls, in a very basic way, in a short version, is that then he asked us to imagine that then we're about to be born to the society. And we know kind of social institution, how usually those things work. But we don't know what kind of people we are. We might be rich or poor, different disadvantage and advantage. And then you have to agree on what kind of rules you want in that kind of society. So it's a highly stylized example, but then you are asked to remove yourself because you don't know who you are. The next to it is, and I wrote the bracketing of the personal identities. So this is another study done by Schneiderhan, and he asked a group of participants about the real world problem, but then asked, essentially try to remove their understanding of their ethnicity. So in one group, they primed a lot about, recalling who you are, remember, and then talk about this. The other is no priming at all. So that is one way to say it's non-self, but a real world problem. So these are you can think about the device in a way that we try to make people think, not just the gut feelings. So for the fairness dialogues, to decide which one we should be using, we can once again go back to its purpose. So because we want to explore societal values to inform real world policies and decisions, we wanted our participants to be themselves. And as to the hypothetical and the real world context, we decided to go kind of in between. So we wanted to create a hypothetical space that can be true to evoke imagination. That is the future I want to live. So that's the design. So here is the summary of the design of the fairness dialogues I just talked about. Primarily, purpose is a foundational, indirectly instrumental, process-oriented, and educational. The mode of public value elicitation is the deliberation, where a person communicates with others in a group, encouraged to provide reasons in an inclusive manner. The strategy to encourage reason giving, inclusive dialogue, is bringing oneself to a hypothetical scenario. And this hypothetical scenario, we named it Troutville scenario. So there are carefully designed, simple, open-ended cases focusing on the chosen equity and fairness issues are discussed. So here, I think it's easiest for me to show you the fairness dialogues and how it goes. So I'm going to run a little bit. So this is the first study. We wanted to test the feasibility of fairness dialogues. So theme was the health inequality and inequity. So we tell participants, we're going to show you differences or inequalities in life expectancy in different groups in the fictional town, Troutville. Troutville is a typical mid-sized town in Nova Scotia. Please imagine you and your family live in Troutville. In Troutville, men are expected to live for 70 years. Women are expected to live for 80 years. And is this difference or inequality in life expectancy between men and women unfair? Why and why not? And usually we pause and talk about it, and a group talk like 15, 20 minutes. And then we show this. So it's exactly the same difference, but now the difference is rich versus poor. And we talk again. And then next one is some people in Troutville love extreme sports, such as riding ATVs, rock climbing, and mountain biking. And between the extreme sport lovers and non-extreme sport lovers, we see this difference in life expectancy. So is it fair, unfair, and why you think? So that's the question. And then themes of the Troutville can change. So the one I just showed you was the fairness and unfairness of health inequalities rated. And we also did the personal responsibility for health, which I want to show you next as an empirical illustration. We are currently developing community-based end-of-life care. And the content of the scenario is something that could be true. So this is the case of the hypothetical, but in a kind of could be real. So that then these numbers, 70s and 80s in Canada, you can imagine it could be true, but then it's not from the real data. So that's the kind of somewhere in between that then it's not too abstract, but not too real. And presentation of the scenario is informed by evidence, by which I mean that then you saw the dot chart. So to show the difference in life expectancy. So that is based on our understanding of the literature on perception of graphs and risk communication. And then it is facilitated face-to-face group discussion of the scenario. And then we follow up each individual by telephone interview because we're early stage of development. And a group consisting of typically 6 to 8 persons, and we try to make them as diverse as possible. And little shy of 2 hours for discussion and 20 minutes for an individual telephone interview. So this is the basic format, how we run. So next time I want to talk about empirical illustration of the fairness dialogues. So this is, as I already mentioned, the second study, personal responsibility for health. So here we wanted to try something policy relevant, some issues, value-related questions discussed in a policy, and also personal responsibility for health came up a lot in the first study. So we thought that it might be good to continue. So this is inspired by the previous strategic plan of the Nova Scotia Health Authority. So you can see here that the Nova Scotia Health Authority will engage Nova Scotians to promote and support our shared accountability for health and improvement in health status. So shared accountability, meaning that healthcare system is responsible, accountable for you, but in the people, you have to be, citizens should be also accountable and responsible. And this is not new. It's been discussed a lot in the policy documents for decades. So we thought it's good to follow up. So the case is very similar format we used, but then now you see criminals and non-criminals. And then here also the difference is this difference or inequality in healthy life expectancy between criminals and non-criminals unfair? Why and why not? In the first one, we used the life expectancy because we thought it's too confusing to use healthy life expectancy. But then participants themselves knew that the health is not just to live a good life. So we introduced that in this scenario. And we also had extreme sport lovers and non-extreme sport lovers, same difference. And then here, firefighters and non-firefighters. And then finally, veterans and non-veterans. So how we came up with this is, oh, sorry, I should mention that. And after we show these ones, we asked, are they, these criminals, different people, responsible for their shorter healthy life expectancy? Why and why not? Is Troutville responsible for their shorter healthy life expectancy? Why and why not? And then after that, we also had a little case. Imagine a criminal, extreme sport lover, firefighter, and a veteran all have serious mental health problems. They need regular visit to a primary care doctor, but unfortunately, there is currently only one spot available in Troutville. Who should get the spot? Why? Who should not get the spot? Why? A little background here is that the primary healthcare shortage is quite ongoing, continuing problem in Nova Scotia, so people can understand that happening in Troutville. And then also veterans. So Nova Scotia has a lot of military presence, so people have a personal connection to the veterans oftentimes. So that's one of the reasons we chose. But then why did we choose this? So this is what we started to call choice grid. And this is the product of my late night conversation over email. A good colleague of mine, Dr. Richard Cookson, in the University of York in England, we started to talk about this. And so when we think about responsibility and choice, it looks like there are two different things we typically think. So whether choice is free or not quite free, and the other is a choice is kind of selfish choice or the noble choice. And then I talked about it to Fairness Dialogues group, and then we thought, oh, this might be something there. And then so we picked certain characteristics, attributes that can fit in these 4 areas. And then here we are not saying that this should be, and probably it's wrong. And then probably we have different opinions, and that's okay. But then as a starting point, and if it is a little bit controversial, maybe it's not bad to initiate the conversation. So that's the idea we came up with and why we chose these 4 different attributes. And we didn't show this choice grid to the participants. Participants just saw those cases you just saw. So this is just a conceptual framework for us to decide what kind of how we want to go about the scenarios. So the methods is that the facilitator guided to our in-person small group dialogues, and then we also did the individual telephone interview. We ran 1 urban and 1 rural area in Nova Scotia, and for eligibility criteria, we always took the lay person as non-health person. So if a student or person or expertise lie in health, we said, please, you cannot come. And living in Nova Scotia, adult and able to communicate in English, and also being physically attend a session. We used the recruitment, purposeful, and a snowball sampling. We learned that libraries are somehow amazing. We didn't do anything very special, but in that little flyer in libraries are the great tool. For analysis, we use the qualitative thematic analysis at the group level. So this is the participant characteristics that we obtained. Let me see here. Okay. So we are quite lucky that we saw a lot of variation, diverse background, age, you can see marital status, and then people not that healthy to healthy, and different smoking behavior, education, high to low, income, and employment. So we were quite happy about what kind of people we captured. And then I want to now talk about some of the key findings. And I talk about the key findings about content and then also methods. And start from the findings. First is a personal choice and the 5 fairness arguments we found. So when considering the 4 inequality cases I showed you, participants thought of personal choice as the central concept. So despite the same origin, this key concept led to the 5 different arguments regarding fairness and unfairness of the 4 inequality cases. So for some, the examination of personal choice directly corresponded to the view of personal responsibility for health. The person made a choice and is responsible for the consequence. Hence, these inequalities are fair. So some quote from the participant, quote, they chose to live the lifestyle they live. And I know in some cases, it's just that it's perpetuated because of, the way they're brought up or their environment. But, people break the cycle too, right? You break through, you make your own choices. You've got to stand up and be responsible, end quote. For others, the examination of personal choice questioned personal responsibility for health and resulted in the belief in social responsibility for health. Society failed to help the person, Hence, these inequalities are unfair. So quote, and if everybody doesn't start at the same spot, then everybody can't be expected to have the same opportunities. So I can't hold my hand over my heart and say, well, you made a choice to be a criminal, because he may not have, that individual may not have any other choice, end quote. For a small number of participants in the urban setting, the acknowledgement of a personal choice was connected to the fulfillment argument. The person had their own aspiration and pursued it. Hence, these inequalities are fair. So the quote, they are all things that take a lot of lust for something that the person really wants to do. But these people all probably grew up with a dream and they want to do something, and they go ahead and do it. Even some of the criminals, a lot of them wanted to be a successful criminal, end quote. And for a small number of participants in the rural setting, appreciation of personal choice directly led to the agency argument. The person should have the choice to live their life how they want to live it. Hence, these inequalities are fair. So, quote, if you take away their ability to choose how they want to live their life, then you're unfair, end quote. Finally, a small number of the participants in both groups thought it was irrelevant to ask whether these inequalities are fair or unfair. The person made a choice, and only that person can make the judgment of fairness. So, quote, we are talking about two different groups of people and different healthy lifespans. Is that fair? It's a fact. It is because they are firefighters? Yeah, so is that fair? What would be unfair about it? They don't live as long healthfully. They've chosen to be firefighters. That's great that you're helping the community, but they are enjoying it too. So now I want to move on to the different aspect of the content finding. So it's about the choice grid I showed you. So we observed that something like choice grid existed in participants' mind, but theirs was much more nuanced than our original one. So this is the choice grid we thought about. But for them, this one, for the free and not free, they're really subtle understanding. So the participants made a distinction of the choice to become X, like criminal, and choice to engage in risky behaviors. So let's say health damaging behavior, violence, influenced by the prior choice of the becoming criminal. And then the consequence, shorter life, healthy life expectancy of all of these choices. So it's a quite subtle way they understood this free and not free. And then this selfish and noble, they didn't think this way. They thought about it is the societal debt. So society owes people who make a choice to responding to social need. And then they made a distinction about accidental events, which is like a fire, nature, and the man-made events, that's war. So they are saying that in a greater societal debt when responding to man-made events like wars, hence the veterans, than the accidental events, which is like fire for them, so firefighters. So we owe veterans more than firefighters. So this is, we didn't think about it, and then it was quite, we thought in quite interesting views. Finally, about the content. So there was a clear division between fairness judgment, social responsibility, and healthcare priority. So as you might recall that there was some healthcare resource allocation-ish question at the end. And when we asked that even among people who are like, really advocating for personal responsibility, the support for the principle of equal healthcare for equal healthcare need was very strong. So, quote, "Of course, we have responsibility to act compassionately in all cases," end quote. So findings about methods. So the fairness dialogues enable people to explore reflective views on health inequity and personal social responsibility. The facilitated guided group discussion using Troutville scenario perceived as engaging. This we observed, and then also because we did the interview after the dialogue, we got that. And a person, reason-giving inclusive discussion on people with diverse background appeared to be critical for the function of the fairness dialogues. It's too bad that I cannot go into what that diversity is, but if we have a little time, maybe I can give a sneak in that bit of anecdotes here. So just a little bit about the future directions. So their key questions came up by doing these studies. So these are the first question is, do the deliberative process differ when participants are faced with the decisions that may have actual consequences as distinct from situations where nothing is at stake? So Troutville uses hypothetical. So some people in the literature rightly say that a hypothetical doesn't translate to the real world. So how much is it like do people make a different distinction? So if that's the case, maybe we cannot really use the hypothetical scenario derived discussion to the real world policymaking. Second, how does the quality of dialogues of the fairness dialogues compare to that of the other methods? So we are pretty excited about the quality of the arguments we saw, but we don't know really how different it might be if you use them different ways to deliberate. And in what way is diversity among participants important for this deep thinking process? And is it always important? So this question is quite important for us to start to think about equity, diversity, inclusion, and accommodation issues. And up until now, we have not really anyone who wanted to participate can participate. We didn't go to the particular community, and we are talking about it, but then should we do the particular community alone, or should we mix up people? Yeah, so those are the questions we want to think about further. Short-term plans, we want to evaluate formally if what appear to be working is indeed working. So the quality of dialogues, fairness dialogues, and other methods, what's difference? And then we want to do that in the research way, that then using quasi-experimental methods, pending for a grant. We're hoping for good news. We also we want to formalize key aspects of the fairness dialogues beyond the Troutville. So maybe we need a very explicit grant rule for the reason-giving inclusive dialogues. And then diversity, but in what kind of diversity we are talking about for the good discussion to happen. And we want to form partnership with other researchers to apply the fairness dialogues method to various topics in health and beyond health. Maybe we can do with the education, income, other things. And we want to strengthen the public advisory group on all citizens of Troutville. So this is a kind of really heartening story that then some of the participants got so excited about it. So they just kept coming back. And then we started to consult with them, and they started to call themselves honorary citizens of Troutville. So they're they are part of a research team now. Long-term vision. I hope fairness dialogues will develop as an ongoing forum where societal values can be explored, developed, articulated with laypersons in a context and a time-specific manner to support the health system. So this is going back to my view that maybe the right answer academically cannot be really found. What is right to do there in the real world has to be discovered together. So my dream is that if this becomes kind of an ongoing method to do that, that would be pretty exciting. And then also the other side is that laypersons start to develop the capacity to engage in value-laden questions related to equity and fairness in health and healthcare and maybe beyond. And then I think this is particularly important now that it looks like our society is becoming more divisive. So maybe we can do something here. So before finishing up, I would like to acknowledge people. So Janet Lee is the honorary citizen of Troutville, and she was the first participant, and now we are working together. So she brought on a lot of interesting insights for us. And then also many students listed here came and went to work with us. So it's great, and various funding agencies to support our work. So thank you very much.